I'm a PGY2 at the University of Florida College of Medicine in Jacksonville. The title of my presentation is a case of euglycemic diabetic ketoacidosis caused by empagliflozin. So to start off with, for the introduction, DKA is characterized by the classic triad of hyperglycemia, elevated ketones in blood and urine, and metabolic acidosis. Now, usually an elevated blood glucose level is the hallmark for the diagnosis of DKA. Yet in some patients, they can have serum glucose levels less than 250 with other features of DKA present, and collectively this is referred to as euglycemic DKA. Now, the causes of euglycemic DKA can range from starvation, pancreatitis, prolonged vomiting and diarrhea, pregnancy, use of an insulin pump, and, pertinent to our case, the use of sodium glucose cotransporter 2 inhibitors in diabetic patients. Now, euglycemic DKA is a rare but serious adverse effect of SGLT2 use. Moving on to our case, we have a 74-year-old male that presented to the emergency department from a nursing home for decreased oral intake and fatigue. Past medical history included hypertension, type 2 diabetes, seizures, stroke, PAD, and vascular dementia. Now, per the nursing staff, the patient had not been eating for the past 5 to 7 days and would only occasionally eat a half a sandwich. Now, upon arrival, his initial blood pressure was noted to be 94/49, and he was given 1 liter bolus of lactate ringers as a temporizing measure. His initial labs were significant for a severe metabolic acidosis, acute renal failure, and type 2 myocardial injury. For his physical exam, he did have noted tachycardia. He appeared older than his stated age, sarcopenic appearing, malnourished, and he was only oriented to himself. For his laboratory diagnostics, they're listed as below. As previously mentioned, these labs show that he had a severe metabolic acidosis. He had a non-oliguric acute renal failure, and he had elevated troponins, although that there was no delta present. So collectively, based on the severe electrolyte abnormalities, multiple organ injuries, demand ischemia, and the non-oliguric AKI, and empagliflozin use on his dispense history, a diagnosis of euglycemic DKA was made. The patient was admitted to the critical care unit, and he was started on 100 milliequivalents of sodium bicarb, which was initially done to replace the bicarb deficit due to the severity of the metabolic acidosis. And the patient was also started on IV insulin infusion based on a standard DKA protocol. He was transitioned to subcutaneous insulin and started back on an oral diet after his anion gap closed twice. And his renal function and cardiac biomarkers continued to downtrend and improve. After 2 days, he was downgraded out of the ICU, and he returned to the nursing home a week later with the empagliflozin discontinued from his active medications. For teaching points, it's important to know that euglycemic DKA is usually triggered by an infection, pregnancy, fasting state, or episodes of vomiting. And as I mentioned, this can precipitate a physiological state of relative insulopenia and increased starvation. There's a delicate balance between glucosuria and glucagon stimulation that helps result and maintain a state of euglycemia. Now, management of euglycemic DKA is essentially the same as that of DKA, except for dextrose infusion, which is aggressively initiated at the start. Now, there's a favorable prognosis, but it depends upon early recognition and screening with serum or urine ketones, even when serum glucose is normal. And thus, clinicians should have a high index of suspicion for euglycemic DKA in patients with euglycemia and a high anion gap acidosis with known SGLT2 inhibitor therapy. Thank you.